The following podcast is part of a certified educational activity titled Innovation Takes Shape in SCD, Rewriting Management Principles with Gene Therapy, and Revisiting the Role of HCT. Access the entire activity and complete the post-test at peerview.com/YKX860. Downloadable slides and practice aids are also available.
Good morning, everyone. Take your time walking in. Please bring breakfast. You could bring me some too. It'd be great. I'm Dr. Julie Cantor, and I'm very pleased today to co-chair this program with Dr. Haydar Frangul. And we're excited. We already have some great questions, and we haven't even spoken yet. So we're looking forward to a good conversation. We may speed through some of our slides so we have more time to talk. We're going to talk, of course, about gene therapy today, revisiting the role of stem cell transplant, allogeneic transplant as well. And we're just really excited to have been asked today and thank PeerView for asking us to be here today. But we are going to help you understand the burden of sickle cell, the unmet needs. I'm going to try to speed through that section. I don't think that that's unknown to anyone in this audience. We'll talk about the evidence supporting the use of gene therapy in sickle cell disease. And then where I want to spend at least my time of this presentation is talking about how do you implement this? Who do you talk to? What are the safety and logistical considerations we need to have? So first, talking about sickle cell disease, where are we now? What are the goals of care in this new modern world? I think everyone here is very familiar with the prevalence of about 100,000 Americans. I'm going to tell you it's actually closer to 125,000 Americans. All of our recent surveillance data, thanks to the CDC, really tells us that we've significantly underestimated the prevalence of this disease. And so while these are the numbers we're still using, I will tell you ahead of time that in Alabama, the original numbers that this 100,000 came from noted that we had about 2,300 affected individuals in Alabama, and our recent data gives us 5,236 individuals over a 3-year period living with sickle cell disease in Alabama. So we've underestimated, at least in the South, for a number of reasons, the individuals living with sickle cell disease. So I love this analogy, and it's, I love my analogies in general, but I spend a lot of time trying to explain sickle cell disease to the people that have it. And as an adult provider, I'm amazed at the number of 30-somethings that walk in my door and have never really understood what is happening in their own bodies. So I explained that a car's job is to drop off its passengers. That's pretty easy to understand. The whole job of the car is to drop the passengers where they need to go. The whole job of a red cell and hemoglobin is to drop off its oxygen where it needs to go. If the car doesn't have all its tires, or if the tires are different sizes, it makes it harder to get where the car is going. If the hemoglobin is missing chains, or the chains are abnormal and of different sizes, obviously it makes it harder for that red cell to drop off its oxygen. But it's actually not just a red cell problem. And so this used to be the way we thought about it. It was just red cells, nothing else to do with concerns about any other, cellular effects or vascular issues. And we now know that's clearly not the case. Instead, there's a lot of traffic in those blood vessels. So these inflammatory interactions really cause a significant amount of traffic that leads to the downstream issues that we see in sickle cell disease, especially the white blood cells, endothelial and activated cells, and then platelets that like to come to any party and really kind of muck up the atmosphere. And of course, activated macrophages that I think we still need to better understand their role in sickle cell disease. So it's not just a car, it's everything happening on the highway. So when I explain this to individuals living with sickle cell disease, I explain that the neutrophils are the garbage trucks. That makes sense, they have similar roles. And if you imagine that you have 17 more neutrophils or 17 more garbage trucks on the street, that's going to create a lot of traffic. And that really helps them understand why when they get sick or when they very unfortunately get steroids from the urgent care down the street and have all these extra neutrophils, they're going to have more pain and more vaso-occlusion. And as you know, while we talk a lot about pain and vaso-occlusion in sickle cell disease, in some ways that's the least of our problems. Not the pain per se, but the vaso-occlusion that leads to all the downstream organ damage. And every single organ can be affected. Unfortunately, there's not an organ in sickle cell in the body that remains unaffected because every organ in the body relies on oxygen. And if the oxygen's not getting in a timely manner where it needs to go, we're of course going to have downstream complications. However, acute pain is one of the highlights and really one of the greatest complications because of its effect on quality of life. And we know that individuals living with sickle cell disease really highlight pain as one of the biggest barriers to their living a fulfilling life. We also know that once individuals have a pain crisis, and especially if they're admitted to a hospital, and especially if that hospital is not familiar with sickle cell disease, they're going to be at increased life-threatening complications. So while pain itself is not going to lead specifically to multi-organ failure, hospitalization may, as well as acute chest syndrome and even death. And there's an associated increase in individuals dying over the age of 20, and specifically due to between the ages of about 18 and 35. And a lot of that has to do not because they're having pain crisis, but because they're having pain crisis and they're getting into a hospital, which of course is the best place to get sick. And so while pain is our most common complication, we also need to make sure that the pain that someone experiences is due to sickle cell disease, which I think can be difficult, as we're going to talk a little bit more later. And I do want to call out this painting by Hertz Nazaire, who died due to sickle cell disease, but I still think it's really one of the best ways to express how people feel when they're having a pain crisis. So I still like these graphs as well. This is looking at how vaso-occlusive crisis or vaso-occlusive episodes contribute to early mortality and sickle cell disease-related healthcare costs. I don't think these graphs need too much explanation, but the bar graph, the left side on the y-axis, is your total annual costs. And unsurprising, when you're admitted for a vaso-occlusive crisis, those costs go up. The more crises, the more cost. We ended here with greater than 10. I have some individuals who, when they come to me for the first time, have been in the hospital 33 times in the year prior. So you can only imagine their cost to the healthcare system. On the other side of the graph, we have mortality and sickle cell disease, and this graph is now getting a little bit outdated, but it still shows that while we've significantly improved childhood survival, we still have a ways to go with improving overall survival. It also really points to that increase in risk of mortality in the middle years, and by middle years, I mean 15 or really 18 to 35. And there's a lot of reasons that often get blamed on transition. The issue is kind of a false narrative. The age range of 18 to 35 is a problem whether or not someone is in adult care. So that age range has a lot of risk factors, mostly that I find that brains in 20-year-olds seem to go backwards and not forwards. And so we have behavioral issues as well as just learning how to adult and balance sickle cell disease, regardless of whether you're currently being treated in an adult program. So where are we now? I really did like this graph looking at the timeline from when the cooperative study of sickle cell disease was really done, the PROPS study that was monumental in establishing the risk of strep pneumococcal infections and the need for penicillin, where we first started using hydroxyurea with the MSH study, the STOP 1 and 2 studies, baby hug, twitch, going forward, of course, to the SUSTAIN study of crizanlizumab, to L-glutamine, though those are actually slightly backwards. L-glutamine came first. And crizanlizumab and voxelotor, which were approved in 2019, and of course, the most recent withdrawal of voxelotor. And where are we now? In 2023, we had the approval of lovo-cel and exa-cel, both approved for the treatment of patients greater than 12 years of age or 12 years and older with sickle cell disease and recurrent vaso-occlusive crisis. There are other therapies in development, and we certainly don't want to exclude that not everyone will ever get gene therapy, no matter how good we make the access. And not everyone will always want gene therapy. So what else is happening out there? Well, some really exciting, actually, I find, studies are in development. So the PKR activators, etavopivat and mitavopivat, and there's a new one that has a new name that starts with a T, but I don't remember what it is. That's also being studied. And these are all pyruvate kinase receptor activists that actually increase the lifespan of the red blood cell, improve its durability as well as its energy, and are in studies to see if it will reduce vaso-occlusive crisis. And then there are these really exciting WIZ degraders. There are two that are in development. I'm not going to spell those out for you, but by different companies. These are small molecules that significantly increase fetal hemoglobin through a different mechanism than we've seen before. And we're going to see some phase 1 data, I hope, in the next year or so. From there, it's my pleasure to introduce Dr. Frangoul to talk about making choices with gene therapy.
Thank you, Julie, and thank you for the invitation to talk to this group. What I'm going to concentrate on is potentially curative therapies and where is the field moving or what is the data available to date. So as you know, we are going to talk about a patient here. This patient is a 22-year-old gentleman with sickle cell disease who had 4 vaso-occlusive crises in the last 12 months, 5 total hospitalizations over 2 years, currently on hydroxyurea at the highest dose that the patient can tolerate, And then David comes into clinic, and this is a usual story in our sickle cell clinic as well as transplant clinic, where he inquires about a potential transplant versus gene therapy for the disease. Is this the type of patient that you clear for as a transplant candidate? Is he a good transplant candidate? What have been the historical challenges associated with transplant and sickle cell disease, which I'm going to touch on here in a minute? And what are the risks of post-transplant complications, including infection, graft versus host disease? And how do you balance that with the need to address the recurrence of VOEs that this patient is experiencing? Is this a patient also candidate for gene therapy? Given the longer follow-up with transplant, we know that gene therapy, the longest follow-up is not as long as allogeneic transplantation. What would you recommend for this patient, and how do you counsel them? How do you tell them about what is involved in each of these therapies? And I think this is something we are facing every day in our clinics, where patients come in and we have to explain to them that there are more than one option now for curative therapy. So what I'm going to talk about today, what I'm going to concentrate on, I know Julie talked about hydroxyurea and other disease-modifying therapies. What I'm going to concentrate on is transformative therapies for sickle cell disease. And I'm going to start with stem cell transplant and end with gene therapy. So as you guys know, that the best result with the sickle cell disease transplant is in the actually identical sibling setting, although only around 18% of the patient will have an unaffected actually identical sibling that can donate. This is data from Elaine Gluckman's paper in Blood that basically looked at a large cohort of patients with sickle cell disease, underwent actually identical sibling transplant, and basically all the patients received myeloablative therapy with busulfan as the majority of the patients. And as you can see here, the patients less than 16 years of age fared better as far as event-free survival and overall survival as compared to older patients who are over 16 years of age. And the 5-year graft versus host disease-free survival was also improved in individuals who are less than 16 years of age. Well, unfortunately, not everybody has actually identical donor. So I know Shalini is in the audience here. She ran a CTN trial, look at related donor transplant, and reported this in Blood. And they enrolled 29 patients that were treated. They were all young patients. The median age was 14, ranging from 6 to 19, and all received 8 out of 8 allelic matched unrelated donor transplant. And the indications are listed here. The majority, there were 12 that had stroke and 12 that had VOCs, 2 had abnormal TCD, and 2 had a history of acute chest. The event-free survival for this group was 68%. And I think what highlights what the problem here is this graph, that the risk of graft versus host disease, specifically chronic graft versus host disease, was unacceptably high in this clinical trial. And I think the conclusion of the paper was that the risk of GVH was too high, that something has to change, and we should not pursue this type of therapy in patients. Adotullah Qasim presented data, and I need to thank him for sending me the slides at a late breaker in 2023 at ASH. I have not seen the data published yet, but this is a CTN 1507 trial using haploidentical transplant to expand the donor availability for sickle cell disease. This trial, I will walk you through it. It included a pre-phase of hydroxyurea for 70 days prior to receiving the reduced intensity transplant with thiotepa, cyclophosphamide, fludarabine, and 200 centigrade TBI. And the GVH prophylaxis was high-dose cyclophosphamide on day 3 and 4, and then remaining sirolimus and MMF. They reported an event-free survival at 2 years of 88%, and the results looked very appealing. There were 42 patients treated. 3 patients experienced either primary or secondary graft failure, and the transplant-related mortality was 4. Now, one of the patients actually 2 of the patients were not included in the EFS analysis. 1 patient who died during the hydroxyurea phase, and 1 patient that died late beyond the 2-year period, but there were 4 mortalities on the trial. And severe chronic graft versus host disease was very low at 3 patients. So I'm still looking for the updated data, which we are all looking forward to, but this is another option for patients who lack a actually identical sibling. And I just want to spend 2 minutes, because I know when gene therapy is being talked to in the last several years, there is a lot of concern about the potential long-term risk of developing secondary malignancies. Now, Mary Eapen reviewed 1,000 transplants for sickle cell disease between 1991 and 2016, and there were 22 secondary neoplasm. And the type included leukemia and MDS in 15 patients and solid tumors in 7 patients. So the 10-year incidence of secondary malignancies, even with allogeneic transplantation, was 1.7% for leukemia and MDS and 2.4% for other all secondary malignancies. Now, I just want to profess here that the leukemias and MDS happened in patients who either experienced graft failure or had mixed chimerism long-term. So what about gene therapy? So gene therapy is very appealing in this setting because you are not needing a donor. This is an autologous product. So the patient journey in gene therapy is quite different than that in an allogeneic transplant. So I always tell my patients, the allogeneic donor is usually available, either haploidentical or HLA identical donor, and you evaluate the patient, you evaluate the donor, and you can take them to transplant electively within a certain convenience to the family, and you do the transplant. While the journey for gene therapy is quite different. It's usually lasts from the time you meet a patient to the time you infuse the cells, sometimes upward of at least 1 year. So what does the journey look like? A patient will come into clinic, you evaluate them if they want to pursue gene therapy. They undergo extensive either transfusion therapy or exchange transfusion for at least 4 to 8 weeks prior to collecting peripheral blood stem cells. And I'm going to show you from the data to date, most sickle cell individuals will require more than one stem cell collection cycle. And the cycles are usually a month or 2 apart. So you're talking about 1 to 2 months of exchange transfusions, and then 1 or 2 cycles, or sometimes 3 cycles of peripheral blood stem cell mobilization. And then there is a manufacturing period. And then the patient will receive the therapy. So it's a longer journey, but the recovery from it, as I'm going to show you, is much faster. So there are 2 approaches currently that are commercially available, and I know Julie alluded to them, is the Casgevy, which is a gene editing approach, and the lovo-cel, which is the Bluebird product, which is a gene addition approach. The Bluebird approach is using a lentiviral vector to add a functional hemoglobin into the genome, so the patients will express that hemoglobin and decrease the severity of the disease. While gene editing, all the approaches used to date, and I'm going to talk about here in a minute, are to increase fetal hemoglobin in the red blood cells and preventing polymerization of the hemoglobin and decreasing the symptoms. So I'm going to start with exa-cel. So BCL11A suppresses the production of fetal hemoglobin by suppressing the gamma globin production. Editing of the BCL11A results in reactivation of gamma globin, and that was shown in the preclinical data in mouse. Exa-cel is produced ex vivo using editing of the erythroid-specific enhancer region of the CD34 HSPCs and reduces the erythroid-specific expression of the BCL11A, upregulating the production of gamma globin and increasing fetal hemoglobin. So this is data that we published a year ago, and I'm sure a lot of you know the swim plots, which all of us like to use in this research. So just to orient everybody, the area on the left, which is in light gray, is the 2 years prior to enrollment on this trial. The red bars indicate the time when the patient is receiving red blood cell transfusion after infusion of the product. And then the blue part is the 60-day washout. All patients in all gene therapy trials to date receive high-dose busulfan over 4 days that is PK adjusted to be myeloablative. I just want to make sure that is very clear. And here on the right side, on the green bars, represent the number of VOCs that the patients had afterwards. Each diamond on the left represents a VOC pre-enrollment. So the patients stopped transfusion at an average of 20 days. 29 of the 30 patients remained VOC-free through follow-up. And 1 participant had a VOC in the setting of Parvo B19. I just want to mention that the patient dropped his hemoglobin but did not require transfusion and was fully recovered and has since been VOC-free for 12 months. We presented updated data at ASH this year that was presented yesterday by Steve Grubb here in the meeting that shows that the long-term follow-up is now to greater than 5 years, that demonstrate that sickle cell participants achieved durable clinical benefits. 93% of them achieved freedom from VOCs, and 98% of them achieved freedom from hospitalization for VOCs. And I just want to mention here that the exa-cel trial defined the definition of VOC as any visit to a facility. So you can come to an infusion clinic, you can come to an ER for an hour or two, get fluids and narcotics or IV NSAIDs, and that was considered a VOC. You did not have to be hospitalized to be considered a VOC. And what the trial also showed, and we showed this again at ASH, that there was a substantial increase to normal or normal level of the total hemoglobin and maintaining a fetal hemoglobin of around 40%. And multiple groups have shown, including Marty Steinberg's work, looking at the amount of fetal hemoglobin you need to actually make the patients asymptomatic, which is in the 25 to 30% range. And all the patients had either 40% or higher fetal hemoglobin. And we also studied in this clinical trial the patient-reported outcomes, and there was significant improvement in all measures of patient-reported outcomes after this therapy. And we presented this data separately at ASH. I'm not going to go over it here. Switching gears to gene addition, this is the data from Bluebird, and this is the results. And again, what they did is they used a lentiviral vector, transfected the hematopoietic stem cells to add a functional hemoglobin A, which is called hemoglobin A T87Q. And after 60-month follow-up, 88% of the patients achieved complete resolution of all VOEs during the 6 to 18-month assessment period. And 100% of the adolescent patients, those are basically over age 12 to less than 18, demonstrated complete resolution of VOEs during the 6 to 18-month assessment period. And this data was updated at ASH this year. This was presented in December. And what it shows is that the duration of VOE-free among participants who achieved VOE-CR was 42 months. 100% of the pediatric patients who are less than 18 achieved VOE-CR, and 11 participants had VOEs post-infusion, 6 experienced VOEs after the 6 to 12-month mark. In the 11 patients who had VOEs post-infusion, there was an average of 84% reduction. So all of them received clinical benefit as compared to baseline. And 4 of the 5 participants who did not achieve VOE-CR had a lot of VOEs prior to enrollment. So those patients had more than 10 VOEs. So the VOE-CR overall was 86.8%, and the severe VOE was 94.7%. So what is severe VOC in this clinical trial was requiring a hospitalization or more than 24-hour stay in the emergency room. So they had 2 separate definitions for a vaso-occlusive event. There was also data presented at ASH from the Editas, Dr. Hanna, which actually was presented yesterday too by Dr. Walters. This is a clinical trial using a proprietary CRISPR-Cas12a to target a different location in the genome. They basically do a double-stranded cut at the HBG1, HBG2 promoter region using the Cas12a, and this trial was to date the available data. There are 28 patients infused, and 27 out of the 28 patients remain to be VOE-free post reni-cel infusion. Again, to orient you, the area on the left represent the pre-infusion data, and the area on the right is post-infusion. So there was also early correction of anemia, durable normalization of total hemoglobin, and sustained increase in hemoglobin F to greater than 40%. The markers of hemolysis in both trials, the exa-cel, the lovo-cel, as well as the reni-cel, showed improvement. And there was early and sustained improvement in pain, physical and social pain-reported outcome. Again, the PROs were improved. The safety profile was also consistent with what you expect. All these trials use high-dose busulfan. So all the stuff that you deal with an autologous myeloablative transplant, these patients experience. And I know Julie is going to go over more the SAEs related to therapy. Another group is the BEAM trial, was also presented at ASH. This is a novel technology as compared to double-stranded break using gene editing. This is basically a base editing. It's targeting the same area where reni-cel did, which is the promoter region of the HBG1, HBG2 region. And the team reported on 7 patients, and I know they presented the data again here. This is a slide from the ASH presentation that was last December, and they enrolled 7 patients. What is really notable about this is at least it is early. I just want to profess that there are only 7 patients on this trial. The interesting part is the average number of mobilization was 1 to 2 cycles as compared to 1 to 6 cycles, for example, for exa-cel. So the patients seem to require less mobilization, although it is early in the process. And the interesting part is there was a robust increase in total hemoglobin, and the fetal hemoglobin rose to greater than 50%. In fact, most of the patient had 60+% fetal hemoglobin in the blood. So they achieved a higher fetal hemoglobin in the blood than normalization. The other thing that is interesting in the preliminary data from the BEAM trial is the time to engraftment. In the reni-cel and exa-cel, the engraftment is north of 20 days, neutrophil engraftment, while the neutrophil engraftment in the BEAM trial was 17 days, and the duration of neutropenia was only 6 days. But again, these are 7 patients compared to many more patients in the other trial, and we are looking forward to an updated data from the team. But again, these are very encouraging preliminary data on a slightly different approach to the gene editing approach used by reni-cel and exa-cel. So other new stuff that was shown in ASH this year was, so for any of you who have either participated in those clinical trials or are doing commercial gene therapy for sickle cell disease, the vein of my existence is collecting patient cells. It is very hard. Patients with sickle cell disease cannot receive G-CSF, so we use plerixafor only as a mobilizing agent. So when you use plerixafor only, the patients don't mobilize very well. So individuals with sickle cell disease, you don't see a significant rise in CD34, and that's why many patients require an average of around 2 cycles. So metoxafortide is a long-acting CXCR4I, and this was studied now and presented, the data presented at ASH. And as you can see here in the graph, and I'm going to put the one on the right, the graph on the left shows the at least 3 out of the 6 patients they talked about at ASH, single-agent metoxafortide led to significant increase in CD34 as compared to what we have seen historically with plerixafor. So this data is relatively encouraging because we truly, as gene therapy becomes mainstream and it is open in many centers around the country, I think we need to solve the mobilization problem. So metoxafortide, at least in this data, looks very promising. The graph on the right shows comparing metoxafortide in healthy donors versus sickle cell disease. And it seems that individuals with sickle cell disease, when you give them metoxafortide, they have a much higher rise in CD34 compared to healthy donors. And that might reflect the fact that the marrow in individuals with sickle cell disease is more wrapped up. So I think there are multiple groups now studying prospectively metoxafortide in individuals with sickle cell disease to try to improve our collection process, because one of the big bottlenecks for having a successful gene therapy is stem cell collection, which is not trivial, because these patients require central line placement, require exchange transfusions for 8 weeks before you do the collection. So if we can minimize the number of cycles you need to actually collect and manufacture, that will significantly decrease the duration I talked about from the time you meet the patient to the time you do it. And it will hopefully improve the patient safety, because every time you have to collect stem cells, you have to put a central line in with all the complications with that. So this is something to keep an eye on, and I think I'm looking forward to seeing more data hopefully this year at ASH. I know the group at St. Jude's is running a prospective trial with the NIH and UAB to enroll patients on the metoxafortide trial. Let's move to the next section.
I think we should all be impressed by how fast we're able to talk about these data now, and that you all understand them, because we've gone through so much of this. I think putting this all together really allows us to have more time to talk about the fun stuff. So let's talk about some practical experience. Kind of call this my soapbox these days. So we just talked about that you all agree, David's going to go with gene therapy. We're going to move forward. He's had 4 VOEs in the last 12 months. He's had 5 hospitalizations. He elects to pursue gene therapy over transplant due to distance from transplant center. As we had discussed previously, he had been on hydroxyurea, taken it, put it in his mouth. Russell Ware always used to say, it only doesn't work if you don't put it in your mouth. He's never met about half of my adults. It works even when you do put it in your mouth, just not as well as not having it. And he's had voxelotor when it was available. He was on crizanlizumab. And anyway, long story short, right? We're going forward for gene therapy. So what do we think about when we say, which one are we going to go with, exa-cel or lovo-cel? First, we think about what's approved at your institution. What are you actually going to be able to do? Meaning, what is insurance going to allow you to do? What are the payers going to allow you to do? What's the manufacturing right now? We know there's significant manufacturing delays, anywhere from 4 months on the Bluebird side to about 6 months on the Vertex side. So when we're thinking about all of these are some of the questions that I'm not going to answer for you, but I want you to think about. Why do you think he chose gene therapy over stem cell transplant? Or why did you help move him in that direction, right? We do a lot of shared decision-making with individuals with sickle cell disease. And a lot of the time, I focus on the post-therapy. Where do they live? The management post-allogeneic therapy is intensive. People have to come back often twice a week, once a week to get levels of immune suppression assessed. They often need electrolyte infusions. There's a lot more in that post-treatment phase than there is on the gene therapy side. So sometimes I will err on the side of gene therapy or suggest gene therapy, especially in those people who live more than an hour from a treatment center. And then how do we communicate this whole process? Well, I say it takes about an average of 10 hours. That's how much time I spend with someone before they sign on the dotted line. And when I first talk to them about gene therapy, if they're like, yes, I'm ready to sign, then I say, no, we need to take a step back and spend some time thinking about this. So really, I spend a lot of time explaining each and every part. And then before we get to the next part, I spend more time again going back over it. What are the known safety considerations? We're going to talk more about that in the subsequent slides. And then if they had a stroke, we get this question a lot. I probably see this once a week. Would this change the conversation? Would you still elect to move to gene therapy versus allogeneic transplant, knowing that the data we have is purely observational, there's no randomized data, and that everyone who had a stroke, and these are all on the lovo-cel Bluebird side, did not have significant vasculopathy. So that's usually my deciding factor. If they've had a stroke, but they don't have any significant CNS vascular disease, I'm much more willing to move forward. If they have significant moya-moya, not so much. So other considerations, it's complex, it's logistically challenging. I say this with all the love in my heart to my transplant colleagues. These individuals do not have myeloma. This is not a multiple myeloma autologous transplant. This is important for a number of reasons, and you need to make sure you have your sickle cell specialist on your team. The infertility risk is still a big issue that we're contending with. The cost factor, the questions about long-term safety for data that we just don't have, and how is the risk of secondary malignancy compared to allogeneic transplant? So I want to spend a little bit of time here. You all have seen this slide numerous times, but I don't want to focus on the process itself, which I think you understand. I want to talk about all the in-between and why this needs to be a partnership between sickle cell disease and transplant. So first you have your individual who's considering gene therapy and seeks out a sickle cell specialist. And I'm going to call out a poster that we actually have. I think it's 435, but I might have made that number up. But I think it's poster 435, where we actually looked at all of the individuals who were referred to our center over a 5-year period. So these are all people external to UAB that were referred to us. And I bring it up because their age range is huge. My oldest patient who came in and said, I want gene therapy, was 63. My youngest was 15, by the way. They also are on a range of therapies. Some have never really understood or tried hydroxyurea in a reliable way. Some of them really hear one-time treatment and don't hear one-time treatment that takes a year. Some of them have significant organ dysfunction that really won't allow them to move forward. So understanding these things and making sure that you're truly presenting every option, not just the gene therapy when they walk in the door, is important. When they decide to move forward and you start thinking about, okay, I'm going to have to stop hydroxyurea, please don't just stop hydroxyurea without starting them on chronic transfusions first. Unfortunate experience in doing this, mostly for fertility reasons, I've seen a couple of young men who have died. Why? Because they were stopped, their hydroxyurea was stopped. This has nothing to do with gene therapy. They wanted to have a child, and they were not started on transfusions. They ended up with severe vaso-occlusive crisis and later died, and they were stopped so that they could have babies. So you can't just stop hydroxyurea. You need to start your chronic transfusions and then stop your hydroxyurea. So they get their stem cells, and you get lucky. This is easy and fast, and they only take one collection over 3 to 4 days in the hospital. Now you wait. So who takes care of that patient during the 4 to 6 month window that you're waiting for that manufacturing cells to be ready? Do you restart their hydroxyurea, remembering that it's going to take 2 to 3 months for that hydroxyurea to be working again? Do you keep them on chronic transfusions? Who's in charge? Who owns that individual? And make sure they're getting the care they need in between. Heaven forbid something happens to that individual after you've paid your $2.1 or $3.1 million for their stem cell product. Because even if they are in a car wreck and can't survive to go forward, you've already paid for that product. So how do you keep them healthy? Then when they finally come back in and, of course, get their conditioning and their product, it goes well, they're out of the hospital in 30 days. But when they walked in the door, they were on, let's just say, 20 milligrams BID of OxyContin. And maybe they took oxycodone every time they had a pain crisis, which might also be every time they stubbed their toe. So how do you change that? How do you reverse that mindset? How do you teach someone who's never had a healthy life to become a healthy adult? This is, again, very, very different than what we think about in cancer. Someone who's had cancer was healthy, they had cancer, and they can be healthy again. These individuals have never experienced what I would say, quote, normal adult life should be like. And it's a significant challenge for my young adults. And then this long-term follow-up. Who's going to follow them? Is it really realistic to think that they're going to travel 3 to 5 hours to a gene therapy transformative center? Or should we make their long-term follow-up more accessible? Should they be seen and followed by a sickle cell physician? I think there's a lot of reasons for this that I'm going to hopefully have some time to go into. When we think about the safety profiles, again, you've seen all of this before. I'm going to show you both exa-cel and lovo-cells, with the caveat that almost all of the safety events we see are truly related to the chemotherapy and myeloablation. Everybody gets horrible mucositis. One of my young men who I adore, who went through this process, said, that was just terrible, Dr. Cantor. Why didn't you tell me? I said, not tell you. We spent hours talking about that it would feel like, I'd taken your throat and scraped it with a razor. He was like, you didn't tell me enough. I said, okay, well, what should I say to people in the future? He said, you have to tell them it really sucks. And I was like, so I quote him every time. So I make sure to really do as much as I can to prepare people for this. We all know, of course, they get cytopenic, and there's some other complications they go through that are all really attributed to myeloablation. The longer-term safety experience that we saw recently, again, mostly related to the experience with chemotherapy. They did have one individual who died secondary to secondary infection, not related to the actual exa-cel, but nothing else that we saw of, I don't want to say of significance, but nothing that you haven't heard. Moving on to lovo-cel, we're seeing the exact same things. The myeloablation causes significant mucositis. We see pancytopenia. We see some changes in liver functions. We do not see any VOD in either of these. That's really important. So that leaves us where we are now. So this is the process that we've kind of put together. And again, I know some transplant teams work incredibly well with their sickle cell specialists, and I know some argue all the time. So what does this look like? How do we help David know where to go to get his gene therapy? Because we've decided, we've used great decision-making. Is he going to get treated at your center? Can you do the therapy? What if you only have lovo-cel and insurance come back and says, okay, no, we got to do exa-cel? So most of these individuals have been seeing some physician since birth, not always. That's a whole nother discussion. But they're very trusting, or they know their sickle cell provider well. That's who's usually done this whole process, this shared decision-making. You've done the formal education, standard treatment. You've talked about allos versus gene therapy versus isn't hydroxyurea a great drug. Now you're doing your screening, right? You've gone through your pre-transplant care. And this needs to not just be discussions with you about these adverse events. In fact, one thing we've learned in our institution that's been incredibly helpful is I take them through all of this consenting and all of this a discussion about the adverse events. And then I send them actually to my transplant physician a couple floors up. And I have her go through all of it again, and they hear it differently for a lot of different reasons, but they hear things differently from her than they might have heard from me. So we found that this is a great way to make sure that the individual gets all the information they need. Who else needs to be involved? A lot of people. So you need to make sure if they have cardiac issues going in, if they have renal issues, that we have those individuals involved in the care of this patient. Psychology, can't stress enough the importance of psychology. The question I've started asking people, especially my young adults, is what does well look like to you? What do you think it's going to feel like to be a well adult? And how are we going to plan for that? And it's a question no one's ever asked them. You all sit down, you all agree to proceed. And this, again, is very important, this multi-physician panel. You've confirmed eligible. Now you say that when that individual is in the hospital, you have to continue that multidisciplinary care. I don't know if she's here because the lights are too bright, but Dr. Salzman would say she had never seen people on the number of opiates or quantity of opiates that individuals came in to transplant with some of my adults. And so it's always a hand-in-hand discussion. We co-manage people when they're in the hospital. Transplant takes the lead when they're in the hospital, and I take that back seat, but I'm always available so that I can help move things forward. And sometimes when the patients get scared, what they want is to hear from their sickle cell team. And finally, that long-term follow-up. Who is going to continue not only just to see them for their study visits or their treatment visits, but who's going to make sure that they get everything they need, that they actually get to a primary care doctor? Who's going to make sure they still get their eyes checked, something we've done a terrible job of in the post-transplant world. If you look at our 2021 stem cell transplant recommendations from ASH, which was the hardest article I've ever had to write, by the way, but if you look at it, the reason it was so hard is we had so little data. Again, love you, transplanters, but you didn't get retinopathy exams. You weren't making sure patients were following up and getting albumin and creatinine ratios even. What about priapism? Do you know that sometimes people get priapism post-curative allogeneic transplant, and that can still happen, and how is that managed? These are all data we couldn't even speak to in those guidelines because we just didn't have it. So this is our opportunity to fix that as we move forward and we think about how we're going to collect data. And so that in 10 years, we can say if a 20-year-old or 22-year-old like David chose this, what does he look like compared to what he would have looked like if he had just stayed on hydroxyurea? We have to have that comparative data that's collected systematically. So moving right along then, I want to tell you about our National Alliance of Sickle Cell Centers consensus recommendations for what we said, okay, this is what you're going to need to do, because it needs to be a conversation and a collaboration between sickle cell and transplant. And these are all available. They're on the web at sicklecellcenters.org, so don't feel like you have to take pictures or memorize any of this. But it's talking about where the roles divide. And this is going to be slightly different in different institutions. But you want to make sure you know what is your sickle cell specialist doing in the care of this individual from beginning to end versus who does the transplant assessment, who manages those stem cell collections. We've been doing red cell exchanges on our patients forever. Handing that over to the transplant physician to take over doesn't always make sense. So who is making sure that the patient gets from step to step to step? The hours this coordination takes is also not to be put aside. It takes significant amount of time and a lot of very close coordination. And that doesn't even include the fertility preservation, which takes an immense amount of coordination and timing for those women who are undergoing fertility preservation. So you want to make sure that you have all the people in the room that you need, and you have that multidisciplinary group to make sure they can do a final review. When we think about long-term follow-up, we call these transformative care clinics, and we're looking to continue to enhance them in our institution. But who sees that patient long-term and who helps modulate their care? For the most part, most of the transplant-specific issues are almost resolved by the time they leave the hospital. Sometimes they need a few more transfusions, but incredibly rarely. They're not on immune modulation. They're not on immune suppression. So we've actually started having our transplant physician see them only one time in follow-up, and then they just come back to the sickle cell center, and we do all of their follow-up. So we want to make sure that not only are we assessing their transplant needs, but what sickle cell complications are still there. I have patients that go into this with avascular necrosis. They're still going to need those hips repaired. Who's going to manage that for them going forward? Psychology. I would love to tell you that we all have dedicated psychologists to this process in our centers. We should. That's something that you should be when your C-suite tells you, oh, we want you to do gene therapy, that you say, oh, well, I need a dedicated psychologist. Because the transition from non-healthy to healthy and that outlook can be incredibly difficult for young adults especially. The world of adulting is hard, and then you add in this whole new framework and mindset. And by the way, 50%, actually I think it's now 65% of my patients who've undergone transplant or gene therapy, they're not on Medicaid anymore. Some have lost their insurance because it didn't occur to them that they had to actively continue to maintain. And many of them now have jobs, and so they actually are having private insurance. So making sure these things are there, and you talk about this repeatedly, is important. All right. So with that, we're going to take questions. There are microphones, and be prepared that we can't see almost anything with these lights. So you might have to jump up and wave your hands. There's also the opportunity to submit questions, and we have a pile of questions that were already submitted. So I'm going to go start with those, and we will go from there. Thank you very much for your attention.
So there are several questions that were given to us during the talk. One was, I'm going to address a couple and hand a couple to Julie. One is, was there anything special about the individuals who continue to have pain after infusion of either exa-cel or lovo-cel? I know that when you look at those individuals, the number of stem cells they received did not make any difference. The amount of fetal hemoglobin there is, or modified hemoglobin is not any different. I just want to mention that, and I think Julie touched to this, is managing individuals with sickle cell disease who had pain all their life is really not an easy process. And a lot of those individuals come to transplant with multiple joints that are affected with ABN that's not going to get better with gene therapy or allotransplant. And I know the question asks, how does this compare to allogeneic transplant? And I think allogeneic transplant clinical trials success has been engraftment and no graft versus host disease. They really, if you look at most of the publications, if not all the publications in the allo setting, they don't follow patients for 15 years and collect how many times they go to the ER. Transplanters like to give a kind of touchdown where they engrafted, they have no GVH, they are good, correct? So we don't want to collect any data. So I think if you really truly collect data, it might look very similar to what we see with the gene therapy. The next question was, which I'm going to have Julie address too, is if you are planning for gene therapy for stroke, would you choose Bluebird Bio, Vertex, and especially with the high F, the modified hemoglobin A2K is better? Would you have an issue with patients with stroke?
So I think the stroke question, and I have another one that's similar here as well, is something that needs to be explored in a study fashion, but is also something that deserves a lot of attention. We don't have any data to suggest specifically that fetal hemoglobin versus hemoglobin A T87Q is better. That being said, I'm a hemoglobin A fan. I think that we all have hemoglobin A for a reason, and we don't have long-term persistence of fetal hemoglobin overall. And so I tend to prefer that in the stroke setting. That being said, if they have, and the question I think I got was, why don't you want to take people with significant vasculopathy to gene therapy? I don't want to do that yet because we just don't have the data. And what we do know is that the majority of cells that come out, the majority of red cells someone makes after either of these therapies, about 90% are truly sickle-free red cells. But what we also know is there's about 8 to 10% that are not 100% sickle cell disease free for various reasons, and they still can sickle. And not only that, but they can still cause adhesion. And so what does that mean in the vasculopathy world? I don't think we know yet. That's one reason. The second reason is that those individuals, especially with moya-moya, we don't know if they will tolerate hemoglobins that are higher than 14. We're not sure yet of that information. And so for that reason, I would lean towards the hemoglobin A if I was going to move forward in those individuals. But I think we really have to be careful that we may not be giving them protection. And until we have true data, I think it's going to be very hard to answer that question and to be very secure in saying, oh, you're going to be fine if I do this.
Another question that came in here is why not give more attention to treosulfan as compared to busulfan as a conditioning regimen? I think if you look at the allogeneic data from Europe when they used treosulfan in hemoglobin disorders, the myeloablation was not sufficient. They had to add thiotepa to it to get grafts in. So I still believe, although I don't have any good data to back it up, that treosulfan is not sufficiently myeloablative. And we know that busulfan is shown historically to be sufficiently myeloablative, and you can control the levels in busulfan. So I'm not sure we have enough data to just use treosulfan in patients with sickle cell disease undergoing gene therapy.
So I'm going to take a different opinion there in that I think we are actually, as we sit here, we are planning a study of treosulfan. We didn't consider it before because we couldn't. It wasn't FDA approved at all, and it wasn't available in the United States. But we absolutely need to answer this question. Treosulfan requires less monitoring. It long-term is less expensive. It causes less toxicity to the lungs. I think it's a very important question, and there's potential that it actually is less gonad toxic. So we need to answer that question. I'm not convinced that it's not myeloablative enough, and I think what we need is the study to look at that. So we're hoping to pursue that in the next year.
Yeah, don't use that without a study. I just want to mention that. It needs to be studied.
So I think you brought up a really good point and something that's incredibly important. And I don't have that exact question, and I don't know if you can see that I have about 20-something questions written here. So, but one of the questions is, do you stray from what was done in the studies, essentially? Would you use different myeloablative therapy? Would you consider using GCSF? Please don't. Remember that these therapies are right now at the pinnacle. We are just starting the commercial process of using these therapies. And if you decide to go rogue and use GCSF because it's hard to collect these individuals and someone has a death, that's going to take us 1 to 5 years backwards. What happens if you decide that you don't need to keep their platelets greater than 50,000 and someone has an intracranial hemorrhage? Again, these are issues that right now we cannot afford to do wrong. We have to make sure that not only are we careful, but we dot our I's and cross our T's. We desperately want people with sickle cell to be able to get these therapies. And so we need to make sure that for now, we do them according to the cookbook and that we don't deviate from the recipe until we have data that suggests otherwise, because all our payers need is another excuse not to pay for them.
Great. One more question here, which is interesting, and I think that's close to my heart, because when are we going to offer this other therapy to other subtypes beyond SS? Now, I know S beta 0 and S beta plus has been studied in those trials. SC disease particularly, and luck has it, when Casgevy became commercially available, our first 3 referrals all were SC patients, and we had to tell them we don't have enough data. You know, when we reviewed the literature and we continue to look into this, there is not enough data that persistent fetal hemoglobin in SC patients is actually prevent polymerization. Theoretically, it should, but we don't know. And I think we need to do a clinical trial in SC patients specifically to actually study them and make sure that either adding a hemoglobin A or increasing fetal hemoglobin specifically will actually be beneficial to these individuals. So I don't have the data to say that go ahead and use it in SC patients. So we have been counseling those patients that we should wait for a clinical trial to open.
I have a couple of questions here about vaso-occlusive events that happened post-gene therapy, as well as questions about chronic pain. And I think that these deserve a lot of additional conversation and exploration. So we've known for a long time that pain is heterogeneous. It's hard to quantify. It's hard to identify. We have people who come in who always tell me that they're having a crisis, and I am able to know them well enough because I've been seeing them to know that really they went to the mall and walked too long on their avascular necrosis hip. And to them, it feels the same. The pain hurts just as much. And so while they yell at me, which is frequently the case, and tell me they know their bodies and I don't, that's true. I don't live in their body, but I do know that not all pain is a vaso-occlusive event. And I think that that's really important as we move forward, is that we can better characterize these events. So one of the things that we are doing a study on now is subdividing vaso-occlusive events into inflammatory events, hemolytic events, where you can use biologic measures in addition to the complaint of pain. I think that we have to take this approach moving forward, and it's actually an area where we have to work together as a community to push back to the FDA. The FDA is continuing to require pain as an outcome or vaso-occlusive crisis as an endpoint. And this is such a difficult endpoint. It's led to multiple therapies either failing or coming out equivocal. So if we can identify which vaso-occlusive crises are actually going to be detrimental, which we can, there's a lot of data that demonstrates that those that are more inflammatory, hemolytic, or associated with thrombocytopenia are going to have more severe outcomes. Why can't we use that as a much more defined endpoint that we can study? And so I think that's one of the questions we have is all pain vaso-occlusive crisis? No. So how do we differentiate that in a way that still allows for patients to get pain management when they need it? So we hope to move forward with that. The second question is about chronic pain. And again, I'm going to tell you that pain is caused by lots of things. I don't know about you guys, but after 12 hours of flying on the way here, my hip is killing me. And so, right, I have chronic pain in that hip every day, and that's not going to go away. And that's not going to go away in people with sickle cell disease either. So what type of pain do they have? How do we characterize and classify that? It's going to depend on whether it so-called resolves. I also want to stress that opiate-induced hyperalgesia is a real problem. And we've now started to publish some work on the use of Suboxone in adults with sickle cell disease, a few of whom have had transformative therapy. One of the patients in the lovo-cel trial who went to the hospital still about monthly after receiving gene therapy with some of the best-looking labs you could ask for, hemoglobin A of 55%, detectable haptoglobin, hemoglobins of 12 to 14, could not differentiate the type of pain that she had. After many arguments, and she fired me twice along the way, we decided to start her on Suboxone for opiate-induced hyperalgesia, and she now works full-time and no longer has any chronic pain. So we need to really start to understand what type of pain people are having and how to optimize the treatments that we have.
I think we have time for one more thing that I want to address, which I think this is very important. How these trials looking at end organ damage long term. I think this is a very important question, and we have really pushed the sponsors, both sides of all of these trials, that we need to continue to monitor these patients for the 15 years and beyond to make sure that these therapies are not only helping with VOEs and VOCs, that they are actually helping prevent end organ damage long-term in individuals with sickle cell disease. And that remains to be a big question mark, but I think it needs to be studied and need to be studied prospectively. I think on the clinical trials and hopefully in the standard of care patients that are receiving commercial product.
I also think this is the perfect opportunity to finally get those long-term data that we desperately need, and to make sure in the data that you are getting on your individuals and the long-term assessments that we're doing in gene therapy, that we parallel those with allogeneic transplants. Because just because we're getting vaso-occlusive crises post-gene therapy doesn't mean you shouldn't be asking that question post-allogeneic transplant. So that's going to be very important, and something we have set up with the Alliance is a registry called Granddad. I didn't make up the name. Globin Research Network for Data and Discovery that focuses on sickle cell disease-related end organ complications so that we can truly capture this in people who get allogeneic transplant, patients who get gene therapy, and people who continue on their current standard of care therapies, because we have to have same data collection across the board. And I think with this, we can truly move this field forward and finally have answers to questions that we should have had a long time ago in sickle cell disease. I think we both want to thank PeerView again, thank Vertex for sponsoring, thank University of Wisconsin for our CME. Thanks to all of you for your attention. And I apologize up front. We didn't get to all the questions. Feel free to reach out to me by email. I'm sure that Haydar would feel the same. We're happy to help in any of these management questions. And thank you again for your attention so early in the morning.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Vertex Pharmaceuticals. To access all materials for this activity, visit peerview.com/YKX860.